like to introduce Dr. Annie Joesph and Tom Lewis. Thank you both so much. I can see you're present, and I'm going to read your bios if you don't mind. And then we've got about 20 minutes for your session, and I'll flag up when we've got a couple of minutes before questions. So Annie Joesph is a consultant microbiologist who leads on the antimicrobial stewardship at Nottingham University Hospitals and NHS Trust, and she's also a member of the Antimicrobial Guidelines Committee for NICE, and she's also a former Innovation Fellow for Health Education England for the East Midlands. And she's worked to improve and integrate the appropriate use of diagnostics and antimicrobials in primary and secondary care, developing a strong interest in UTI and diagnostic stewardship. And Dr. Joesph has subsequently has subspecialty experience in community microbiology, urological and obstetric infections. She's worked on several national guidelines and committees relating to diagnosis and management of UTI. And together with Dr. Tom Lewis, established the National Complex UTI Multidisciplinary Team Forum to support and develop the management of complex UTI across the country. Are you going to speak one after the other? I can introduce Tom subsequently. Or
you could introduce Tom now. I think he'll just roll straight on from me. Yeah.
Perhaps I'll read Dr. Tom Lewis's bio as well. So Tom Lewis is a consultant microbiologist from North Devon and a lead on antibiotic stewardship, and he's a national lead for the Pathology Get It Right First Time programme, and has been also involved in developing training materials for Target, which is a national antimicrobial stewardship programme for primary care. And Dr. Lewis has expertise in supporting patients with hard to treat urinary symptoms in this group, which is often recognised, a group which is often recognised to be underserved and under-supported. And locally, he's run a recurrent UTI clinic jointly with urology colleagues for over 6 years, and he was involved in setting up the complex UTI MDT as described. So thank you both very much. We really look forward to the next 20 minutes.
Oh, yeah, okay. Right, I'm going to kick off with some of my thoughts about uncertainty in urinary tract infections, which is a bit of a big topic. So I'm just going to try and distill some of them down. Myself and Tom have both known Eleanor for a little while, and whenever I hear her speak, I always just think, oh, so good to listen to. She's so good to listen to. I can't actually remember how we all met, but we've had long discussions between the three of us about uncertainty in urinary tract infection. Perfect. Okay. So I'm aware there's probably a sort of a mixed audience, but why do I think UTIs matter? Well, massive global burden, millions and millions of infections, majority are in women, but clearly it affects men as well and throughout life. So an issue for pediatrics all the way through to end of life. It's one of the top reasons why antibiotics are prescribed, so a huge area in terms of concerns around antimicrobial resistance. And as I'll talk about in a minute, I think it's a really neglected area of infection medicine. The diagnostics that we have available for it at the moment are basically inadequate in my view, and that often feeds into the not just the physical impact of UTI, but also the psychological and social aspects of UTI as well. Next slide. So for me, I think that UTI, as somebody mentioned in that in the chat on that when Eleanor was talking, this is a suite of diseases. It's a spectrum disease. It's not one thing, and that disease model of it being one thing has been unhelpful in terms of diagnostics and management of this condition. And essentially, this is a disease model which is built on the myth, and everything around diagnostics and management has come from the myth that urine is sterile. And I started medical school nearly 20 years ago, and I was taught 20 years ago that urine is sterile. I don't know what's taught now in medical school, but this myth that urine is sterile is just prevalent everywhere amongst all sorts of healthcare professionals of all grades, and also patients and people generally. So we've built this disease idea that it's a single condition, and that it happens when urine that is sterile becomes no longer sterile and you have bacteria in it. and the diagnostics are based on this foundation. And almost all of the UTI treatment studies historically have had positive urine cultures as an inclusion criteria. And most of the drugs that have been approved have that as a positive an inclusion criteria for their licensing studies, and that's because the FDA still asks for microbiological clearance as a proof that your UTI antibiotic actually works. So we've kind of got layers of it's like a house of cards built on sand, essentially. And I think it's only been in the last 10 to 15 years that the house of sand has started to become a little bit more solid in terms of the science. So if you go to the next slide, I'm going to talk a little bit about the microbiome, and I'll call it the urobiome. So I'm really talking about the urogenital tract and everything that lives in there that's not part of us human beings. So the microbiome, I'm sure people have heard the word, but essentially it's a combination of the microbiota, which is all of the microorganisms in an ecological niche, alongside everything that comes with them. So molecules, signal molecules, toxins, proteins, their DNA, their RNA, things that move between different types of microorganisms, and the environmental conditions. So the bladder is its own ecological niche and has its own microbiome, which I'll call the urobiome moving forward. So if you go to the next slide. So where are we at with urobiome research? So it started later than pretty much all other anatomical niches. So the gut microbiome has kind of been around as a trendy topic for 20 odd years or so, and the Human Microbiome Project, which was a large sort of funded research project, started looking at 4 or 5 different anatomical niches, and this was in the early noughties, to really characterize what is the human microbiome at these sites. And interestingly, the bladder was not one of those sites. So even in the early noughties, there was still that belief that, well, we don't need to look at the bladder as a microbiome site because it's sterile. Although there was work back in the 70s and 80s done by Rosalind Maskell showing that the urobiome was not sterile, the urine was not sterile. But it wasn't really until the advent of next generation sequencing that had really the techniques and the bioinformatics that came along with the sequencing of other biological niches like the gut microbiome has then been applied to the urinary tract, and we've started to really see good data coming out about what this is. So what does next generation sequencing and shotgun sequencing give us about the urobiome? So it essentially gives us the relative abundance of different groups of bacteria. So if looking at those 2 graphs there, you can see all different colours, all different types of bacterial groups, essentially taxonomic groups. And the different colours and the different charts, each column is one person that's been included. So you can see that on the left-hand one, that's some patients who have urinary symptoms, and the right-hand columns are the ones with no urinary symptoms. And what you can see is actually there's quite a lot of overlap there. So there's lots of people who have all of these blue things. It doesn't really matter what the names of them are. So lots of blue abundance. Some people who have lots of red abundance. Some people who have lots of green abundance. There's lots of greys going on there in the background. So they sort of come up with this idea, which I think is a good one, that we have these community state types, which are essentially similar patterns of microbiome amongst people that you can kind of put together. So, for example, for the vaginal microbiome, there's sort of 5 community state types, where if you sampled everybody, most people would fit into one of those sort of states of their microbiome. So we don't have the same microbiome each. There isn't one normal state for us. People are naturally different, unsurprisingly, but that has huge implications for how we would one, diagnose people with a different microbiome state from each other, and 2, implications for treatment. So why would people with different normal states respond exactly the same to different treatment modalities? Of course they won't. We've got, it's a living ecosystem that's not part of us. It's its own ecosystem, so it's not going to respond to the same in the same diagnostic tests or in the same treatment. So yeah, this paper that I've just referenced there that the chart is from is really good if anybody's interested. It's like a really short review of where we've got to with the urobiome, the history, and where we kind of got to. It's a couple of years old, but it is really good and it summarises it really nicely. Next slide, please. So what do we do now then? So I've shown you what's possible. What do we actually do in clinical practice? So the current clinical practice still relies upon what I'll call standard quantitative urine culture, which is basically plating out onto agar plates and counting the numbers of various different types of bacteria that grow. And that's still based on the CAS criteria, which was developed in the 1950s. Lots of research have shown that this method is ineffective for the diagnosis of cystitis and recurrent UTI, with between 40 and 50% of infections being missed. But this is the current standard of care. Why is it the current standard of care, even though there's loads of evidence to say that it's rubbish? Convention, dogma. There isn't really a cheap, viable alternative yet in terms of it being replaced with something different. It's embedded in all the national and international guidelines, FDA studies. Everything hinges on these criteria in this test, which is old and not very helpful. But the whole house of cards has kind of been built on top of it. So I'm going to hand over to Tom, because Tom has done some great work in terms of data analysis of what can we actually do with this information that we have now from testing, and how can that inform us what to do when we're uncertain.
Thanks, Annie. And if we start with the next slide. Oh no, this is still Annie's slides.
Oh yeah, I forgot this. I was going to, yeah, I've kind of summarised this already, but I've got a couple of little graphs here. So the first graph is about people who have no infection. So if you do a standard urine culture on people who are completely well, walking around in the community, no symptoms, no infection symptoms, then most people won't grow anything on culture, but a good proportion of people will have bugs that will culture in the urine. Next slide. And then if you take people who have a urinary tract infection or have symptoms that could be attributable to infection in the urinary tract and culture their urine, some of them will have very few bugs and some of them will have lots of bugs, but there's a huge overlap between these two groups. And the next slide kind of summarises that, in that you've got this grey zone, this area of uncertainty where our standard diagnostic tests do not help us in terms of distinguishing people with infection and without infection. Yeah, I think that's what I want to say. So this is the sort of the area of uncertainty that we're operating in as clinicians all the time.
Thank you. That's the perfect setup. Thank you. And Eleanor's talk as well. Actually, just thinking about how we categorise disease. It's so interesting to hear that sort of thing. As medics, we can forget that a lot of what we do is based on some rather shaky categorisation foundations. So we start with the next slide. Worth saying, I've got Leela Farmer who has done all the data analysis for me here, so who can code. She's sitting with me here, and so all of the data you're going to see in the coming slides is courtesy of her. But if we start off with the gold standard problem, which I think Annie alluded to really, is that most of the literature on UTI is based on culture evidence of UTI. We know that 5% of women are colonised with E. coli in their urine at any one time. And we also know that 20% of women with symptoms have no culturable organism. So already you can see some problems emerging. Most of the literature on symptoms is based on fairly small sample sizes, certainly under 1,000, often less than that, and with slightly pre-selected groups of patients. Often hard to understand how some of these patients get into these groups, but you start off with women presenting with a possible UTI, you're going to have a very different group of patients, which I think is why Eleanor's moved away from that and talking about symptoms. But the data we've looked at locally, so most labs have got 3 routinely collected pieces of information when people send a urine to us. So we'll have the culture results. So this will be seen as the gold standard in a lot of the literature. We also mostly have data on the white cells in the urine, and this shows inflammation in the urinary tract. And we also get some data on symptoms. This depends on how well the clinical request forms are filled in when a sample's sent. But we did quite a lot of work back in 2012 on improving that locally, and we'll come on to that in a minute. But so the questions we asked were, can we use these routine samples to identify common symptoms and work out which culture results are important, whether symptoms and white cell information modifies this interpretation. So really just exploring that large grey area that Annie showed in the last slide. So if we have the next slide, please. So this is looking at routine urine samples sent in women aged 18 to 50 in North Devon from primary care. So that's 28,000 specimens from 2012 to 2022. And Leah's produced this nice word cloud here of the sort of things that get included on the clinical details. And we found out that we could match 50% to actually not very many key words, symptom keywords. And the remainder, 20% had antibiotic intentions, 20% were for screening of early pregnancy, and only 10% had no interpretable details, which was slightly surprising if you've ever come across doctors' documentation. So surprising. Next slide. So we defined core symptoms. So we looked. So this is using more rigorous lab standards. So if you think about, most of the literature just goes on having E. coli in urine as ruling in infection and no growth as ruling out infection. Well, we know that we can certainly add in white cells. So pyuria is the presence of white cells in the urine, and we can say if you have E. coli and pyuria, then you are more likely to have an infection, and no growth with no pyuria, less likely to have an infection. So being a little bit more rigorous about how we define things, we can then look at the odds ratios of these words along the bottom here. These are some of the keywords that we use, and you can see that if they include dysuria, so that's pain on passing on urinating, and pyelonephritis, that's a kidney infection, in their clinical details, then they had strong odds ratios for predicting E. coli and pyuria. And if they specifically mention no dysuria, then that goes against having laboratory evidence of UTI. So that completely fits the literature, what we would expect. Next slide. So we take out the people with dysuria, so specimens where they mention dysuria, and just look at what's left, because dysuria is no doubt, it's in all the evidence, all the flowcharts that Eleanor showed you. Dysuria is the thing that comes out time and time again. So we just take that out and we look at the specimens that are left. So blood remains important. That's actually quite strongly in the literature as well. So that's not surprising. So that's actually seeing blood in the urine, presumably. Next slide. And this, I think, was slightly surprising to me and Annie. So in microbiological training, we're told that smell is not a predictor of UTI. And some of the literature, actually, when you look at it, says it is. But and certainly when you sit in a recurrent UTI clinic, every single patient will say when they get a UTI, their first thing they notice is a change in smell. And smell is a very strong predictor as a word that people use to describe the symptoms of why they're sending in the specimen. And that, I think, is slightly surprising how strong it is. Next slide. And frequency, so this is going more often than usual, is a poor predictor when we remove those core symptoms of dysuria and pyelonephritis. Now, this goes against the literature. So the literature will bang on about frequency as being a key symptom to ask about. And if you look at it, so on the left of this slide, you can see what happens before we take out dysuria. Frequency is a predictor of UTI, but take out dysuria and it goes away. And I suspect this harks to some issues with methodology in the way patients are selected. So frequency is probably quite for those of you with a statistical bent, quite a sensitive marker of UTI. So people who have UTI probably have frequency, but you can't reverse that argument and say that people who have frequency have a UTI, probably because frequency is a common symptom in the population. And if we don't start thinking about these symptoms in a large group of people, we'll get ourselves into problems, I think, which I think speaks to some of what Eleanor was saying. Next slide. That's similar for suprapubic pain. Again, a symptom that we're taught as microbiologists we should be paying attention to. Probably not that helpful. Next slide. So we can come up with a new gold standard. So in our 3 variables. So in culture, we can have E. coli. There's actually some other bugs that are probably quite relevant for the microbiologists in the audience. And the negative there would be no growth. In urine white cells, we can have lots of white cells or not very many white cells. And in symptoms, we now have 2 groups of symptoms. So we can take those clinical details and we can bundle the specimens where they've got positive symptoms and bundle them where they've got negative symptoms, and then call these the gold standards. And we can then judge how they perform against the other 2 variables, as we will come on to. Next slide. So looking at culture. So this is data that's very hot off the press. Leaders got these off about 3 days ago, so I'm still getting my head around these. So I hope you can understand what I'm talking about. But in the left-hand side here, we're looking at symptom rule in and rule out. So this is a negative, either do they have positive or negative symptoms, and then looking at different levels of white cells. On the right-hand side, we see it the other way around. So we're using white cells to rule in or rule out with different symptoms. And we're just looking at 4 different types of culture here. So we've got no growth, mixed growth. So I've got a single top 4. That's E. coli with some of the other organisms. And then Enterococcus is the GPFS, which is mentioned as a cause of UTI in most literature. Next slide. So the first thing to notice is that if you have E. coli without symptoms or white cells, these are the highlighted ones, then you should have caution here. These don't perform much better than other categories, and this is a third. So a third of specimens which grow in E. coli have no white cells, and they're not that strongly associated with UTI. So as soon as you start thinking about that, the literature the house of cards, or whatever Annie called it, starts to collapse quite rapidly. Next slide. But equally, if we look at samples with no growth or mixed growth, again, things that we'd say as meaning no UTI, then these have white cells or they have symptoms. So we shouldn't be discounting these things quite so rapidly. Next slide. And the enterococci, so these organisms that we think do cause UTI, really have no relationship with any. And clinically, whenever I've always felt when we see these in cultures, they don't really mean anything. And this is completely borne out by the data and causes a huge amount of over-treatment, I suspect. Next slide. Absence of white cells is a very strong predictor of negative culture, probably most relevant for microbiologists. Next slide. But then if we have got white cells but weak symptoms, then that still predicts a positive culture. I think that's, if we just move on from that, that's for me to bang home another points to microbiologists. So here are some conclusions. So if you get an E. coli but no white cells and no symptoms, then you should be skeptical of that result. So for microbiologists, we should consider suppressing antibiotics in a report and asking for a repeat specimen perhaps. Certainly getting more history. If you get a low virulence organism such as an enterococcus, then you should treat that as a contaminant unless clear evidence of significance. One could debate what that significance would be, but possibly isolating it from a blood culture. If you get a mixture, however, and I think this is probably most relevant for the literature and for some of Eleanor's points, if you get a mixture, then we should be paying attention to those if there are white cells and symptoms. First thing we can do is we can look for predominant coliforms. We should think about repeating it, paying more attention to how we look after these specimens. They're treated with contempt, frankly. And we should consider the possibility of genuine mixed infection, which are rare, but we see them. And then if we have no growth, then we should pay attention to those if there are white cells and symptoms, and we should think antibiotics. The commonest reason to not grow something is that the patient's already on antibiotics. But if we still can't grow things, then we should think about alternative culture. And I can think of somebody I saw yesterday who I've seen in recurrent UTI clinic, had sent in a sample. I know she knows her symptoms, and I know she's got a UTI. We didn't grow anything the first time we looked. We put it on different plates and looked a bit harder, and it was full of bugs. So that's the problem with microbiology and the way we do most things. And I think that's the end of the slides.